About a 6, I'd say. Sore, but not unbearable.
6 out of 10 on day 1. That's exactly where we'd expect you to be. Hello, and welcome back to Medical Voices, the show where we learn the language of healthcare through real clinical conversations. I'm Nadia.
And I'm Tom. Good to be back.
As always, everything you hear on Medical Voices is here to help you learn the language of medicine. We're passionate about medical English, but we're not your doctors. Nothing in this episode is medical advice.
Last week, we were at Hartfield Medical Centre. Dr. Sharma and Mrs. Walker, a GP referral to cardiology.
This week, back to a familiar face. Mr. Davies is on the other side of a planned operation in a new setting, St. Matthew's Hospital, on a surgical ward.
Episode 9. Post-op care and recovery. The language of the morning round on a surgical ward, pain score, observations, wound check, mobilisation, and the criteria he's working toward before he can go home.
10 terms, a full day 1 nursing assessment, a breakdown, and a quiz. One of the most directly testable scenarios in OET Speaking for the Nurse Profession, and a high-value cluster for anyone at IELTS 6.0 or above in healthcare contexts.
I'll be Mr. Davies. Day 1, post-op, slightly sore, ready to go home if everything checks out. Nadia is the ward nurse. Let's get into it. Before we get into the dialogue, let's make sure we have the right words. 10 terms. Term. Definition. 1 example. Pause and repeat whenever you want to.
2 of these, terms 2 and 8, are recalls from earlier episodes. We'll flag them when we get there.
Term 1. Post-operative. Often shortened to post-op. The period of care immediately after a surgical procedure. Example. Mr. Davies is day 1 post-op.
Term 2. Surgical ward. Recall from episode 4. There, ward was the general word. Today, we narrow it. The area of a hospital where patients recover after a planned operation. Example. Mr. Davies was transferred from theatre to Whitfield ward overnight.
Term 3. Recovery. The process of returning to normal function after surgery, physical and physiological. Example. His recovery is on track for day 1.
Term 4. Pain score. A numeric rating on a 0 to 10 scale that the patient gives for their pain. Out of 10 is what nurses actually say at the bedside. Example. His pain score this morning is 6 out of 10.
Term 5. Mobilisation. Getting the patient up and moving safely after surgery, sitting, standing, walking. Verb form, to mobilise. Example. We'll start mobilising him after breakfast.
Term 6. Wound site. The specific area of the body where the surgical incision was made. For a laparoscopic procedure, several small keyhole sites. Example. All 3 wound sites are clean and dry.
Term 7. Analgesia. The clinical term for pain relief medication, everything from paracetamol to stronger options. Patient-facing equivalents, pain relief, painkillers. Example, he has regular analgesia written up.
Term 8. Observations, or OBS. Recall from episode 5. In triage, we called them vital signs. On a ward, the same 5 readings become observations, recorded at set intervals. Example. A full set of OBS is due at 0800.
Term 9. Bowel function. The return of normal intestinal activity after abdominal surgery. passing wind, then opening the bowels. A normal bedside question, not a sensitive one. Example. Bowel function is one of the things we ask about each round.
Term 10. Discharge criteria. The set of conditions a patient must meet before being safely discharged home. Pain controlled, observations stable, eating, drinking, mobile, transport arranged. Example. Going home depends on meeting the discharge criteria.
10 terms, every one of them in the dialogue coming up.
Ready when you are.
All right, time for our role play. Today I'll be Mr. Davies. Day 1 post-op on Whitfield Ward, St. Matthew's Hospital. Slightly sore, ready to go home if everything checks out.
And I'll be staff nurse Nurse Santos, 6 years on Whitfield Ward, on the morning round. Let's go. Good morning, Mr. Davies. How was the night?
Morning. Slept on and off, really. The painkillers helped. I'm awake now.
Good. That's about what we expect for day 1. I'm Maria, your nurse this morning. I'll be doing your obs, having a look at the wound sites, and we'll talk about getting you up. Can I just confirm your name and date of birth before we start?
James Davies, the 14th of March, 1983.
Perfect. That matches your wristband. And any allergies?
Penicillin, same as on the chart.
Penicillin, confirmed and flagged. Right, let's talk about pain first. Are you sore now?
About a 6, I'd say. Sore, but not unbearable.
6 out of 10 on day 1. That's exactly where we'd expect you to be. The pain score helps us track whether the medication is doing its job. If it climbs to 7 or 8 between doses, tell me. We can give you a top-up. The aim isn't 0. The aim is manageable, so you can move, eat, sleep. Quick aside, med nomads. What pain scale is standard where you trained? Drop it in the comments. We're comparing tools across countries. Right. Full set of observations, Mr. Davies. Blood pressure first.
Go on.
118/76. Pulse, 72, regular. Temperature, 36.8, that's normal. Oxygen saturation, 97% on air. Respiratory rate, 16. All within normal limits. Good.
Better than I'd have guessed.
Now the wound sites. There were 3. Small ones because it's a keyhole procedure. Can I lift the dressing edge to look?
Of course.
First site, clean and dry. Second, clean and dry. Third, clean and dry. No bleeding, no swelling, no redness around any of them. That is exactly what we want to see at day 1.
When will the dressings come off?
The dressings stay on until tomorrow morning. They're waterproof, so a short shower is fine. After they come off, you'll see 3 small cuts with steri-strips across them. Those stay on for about a week, and then they come away on their own. The important thing is what you watch for once you're at home. Increasing redness, increasing swelling, oozing from the wound, or a fever. Any of those, give us a ring or contact your GP.
What about the medication?
You have regular analgesia written up. Paracetamol around the clock, plus a stronger option available if the pain breaks through. We call those breakthrough doses. And you'll have a small daily injection to prevent blood clots. That's anticoagulation. Standard after any surgery.
How long for the injections?
About a week. The surgical team will confirm before you leave. You won't be doing them yourself in hospital. I'll do those. Some patients go home with a short course and a district nurse to help. Others have a tablet alternative. The team will work it out before discharge.
Okay.
Now, mobilisation. We need to get you up this morning. Sitting out for breakfast first, then a walk to the bathroom with me alongside you. Build up across the day. It feels counterintuitive when you're sore, but it's one of the most important things you can do. It gets the lungs working, it helps the bowels wake up, and it reduces the risk of blood clots in the legs.
Even at 6 out of 10?
Even at 6 out of 10, that's why we have the analgesia. Take a top-up half an hour before you stand up the first time, and it makes a real difference. Slowly, no rush. If you feel dizzy, sit straight back down.
Right.
One more thing I'll ask each round. Your bowel function. Have you passed any wind yet?
Not that I've noticed.
That's fine for day 1. It usually starts coming back over the next 24 to 48 hours. Completely normal bedside question. We ask because it tells us the gut is waking up after the anesthetic. Once you've passed wind, opened your bowels, and you're eating and drinking, that's another tick toward going home.
So, what do I actually need to hit before I can leave?
Good question. We call them discharge criteria. There are about 7. Pain controlled on tablet analgesia. Observations stable. Eating and drinking comfortably. Passing urine, bowels working, mobile around the ward, and transport home arranged, with someone at home for the first night. Plus, the follow-up plan understood. What to watch for, who to call.
That's clearer than I'd realised.
We'll go through it each round, and I'll write it on the board above your bed. Today is about pain control and getting you up. Tomorrow morning, if everything's on track, the surgical team will pop round. The discharge summary will be written, and we'll get you home. I was on shift when you came in for the hernia clinic. Different person on the other side of a different problem a few months back, I gather.
Yes, headaches. That all got sorted, thankfully. This is the unrelated one.
Good to have you back, even for the right reason this time. I'll be in again in about an hour. Buzzers by your right hand if you need anything sooner. Okay, let's do 3 key exchanges again, a little more slowly.
About a 6, I'd say. Sore, but not unbearable.
6 out of 10 on day 1. That's exactly where we'd expect you to be. The pain score helps us track whether the medication is doing its job. If it climbs to 7 or 8 between doses, tell me. We can give you a top-up. The aim isn't 0. The aim is manageable, so you can move, eat, sleep. Now the wound sites. There were 3. Small ones because it's a keyhole procedure. Can I lift the dressing edge to look?
Of course.
First site, clean and dry. Second, clean and dry. Third, clean and dry. No bleeding, no swelling, no redness around any of them. That is exactly what we want to see at day 1.
When will the dressings come off?
The dressings stay on until tomorrow morning. They're waterproof, so a short shower is fine. After they come off, you'll see 3 small cuts with steri-strips across them. Those stay on for about a week, and then they come away on their own. The important thing is what you watch for once you're at home. Increasing redness, increasing swelling, oozing from the wound, or a fever. Any of those, give us a ring or contact your GP.
So, what do I actually need to hit before I can leave?
Good question. We call them discharge criteria. There are about 7. Pain controlled on tablet analgesia. Observations stable. Eating and drinking comfortably. Passing urine, bowels working. Mobile around the ward, and transport home arranged, with someone at home for the first night. Plus, the follow-up plan understood. What to watch for, who to call.
5 points from this morning's round. The language moves that scored. The ones to keep in your ear and the ones to use in OET Speaking. Point 1. The pain score. Listen to the nurse. 6 out of 10 on day 1. That's exactly where we'd expect you to be. That phrase, out of 10, is what nurses actually say at the bedside in UK and Commonwealth practice. The numeric rating scale is the workhorse. 0 is no pain, 10 is the worst pain imaginable. The patient says, sore but not unbearable. The nurse converts that into a documented score. That move, plain language to clinical number and back to plain language for the next sentence, is exactly what OET Speaking assesses in nurse role plays.
Point 2. Clinical word and plain English word in the same breath. The nurse said, analgesia, paracetamol around the clock, plus a stronger option if the pain breaks through. Analgesia, then pain relief. Observations, then OBS. Mobilisation, then getting you up. A strong post-op nurse names both deliberately. The clinical word locks the term for documentation. The plain word makes sure the patient actually understood. Always name both. That doubling is a register skill, and it shows up directly in OET speaking marking and in IELTS speaking healthcare topics at 6.5 and above.
Point 3. Wound site language. Clean and dry is a stock clinical phrase. It means no bleeding, no swelling, no redness, no oozing. You'll see it in observation charts and hear it on every surgical ward in the country. And the red flag language going home, increasing redness, increasing swelling, oozing, or a fever, any of those, give us a ring. Notice the hedge, give us a ring, not you must call us. Soft phrasing, firm content. Patient-centered wording for clinical information. OET examiners reward this consistently.
Point 4. Observations on a ward. This is the recall from episode 5. In triage, we called them vital signs. BP 122/79, SATs 98. Compressed, sequential, spoken at the desk. On a ward, the same 5 readings become a full set of OBS. Same numbers, different register. Intervals matter post-op. Hourly, the first few hours after surgery. Then 4-hourly, then less often as recovery progresses. Same vocabulary, different rooms.
And point 5, discharge criteria as a checklist. The nurse named them as a list. Pain controlled on tablet analgesia, observations stable, eating, drinking, passing urine, bowels working, mobile, transport arranged, follow-up plan understood. Naming the criteria up front gives the patient a checklist to work toward. And don't confuse discharge criteria with the discharge summary from episode 6. The criteria are the conditions to leave. The summary is the document on the way out. Different words, different moments. 5 points. That was the breakdown. Now it's time for the quiz, Nadia.
That's right, Tom. Quiz time. 3 questions. Are you ready?
Ready?
Question 1. What is a pain score, and how is it most commonly recorded at the bedside in UK practice? 5 seconds. Think before you listen.
A pain score is the numeric rating a patient gives for the intensity of their pain. In UK practice, the standard tool is the numeric rating scale, 0 to 10. 0 is no pain, 10 the worst imaginable. And at the bedside, the nurse simply says, out of 10. Same scale in adult OET speaking role plays.
Question 2. Name 3 things a post-operative patient is asked to watch for at the wound site once they are home. 5 seconds.
Increasing redness, increasing swelling, oozing from the wound, or a fever. Any one of those, ring the ward or contact your GP.
Question 3. What is meant by discharge criteria, and how does that differ from a discharge summary, which we met in episode 6? 5 seconds.
Discharge criteria are the conditions a patient must meet before they're safe to leave. Pain controlled, OBS stable, eating, drinking, passing urine, bowels working, mobile, transport arranged, follow-up understood. The discharge summary from episode 6 is the written document going home with the patient and to the GP. Criteria: the conditions to leave. Summary: the document on the way out.
3 questions, 3 clear answers. The PDF transcript has all 10 vocabulary terms, the full dialogue, the language notes, and a sample pain assessment record. Link in the description.
That's episode 9. Mr. Davies is one good night's sleep away from going home. Next week, a very different kind of consultation. Episode 10 takes you into a pediatric appointment at the GP clinic. A parent, a child, and the language of talking about a little one's health.
See you next week, Med Nomads.
See you next week.